Taylor, the nurse practitioner up on the NICU floor.
Hey Taylor, it's John over in the pharmacy. I was just going through one of the charts and I had a couple questions on one of the patients. Do you have a few minutes?
Yeah, absolutely, John. Who's the patient you're referring to?
Okay, it's actually baby Sue. That's the 15-day-old. She's in your unit. I was going through the vancomycin dose and found something came up. Wanted to double check on. She's currently 10.2 milligrams every 18 hours, and I was going through and checked our resources here, and I think she should actually be on every 12 hours based on her 29-week age and 14-day being postnatal.
Yeah, I think that's actually a great recommendation. I've been looking at the chart a little bit earlier too, and I saw that the current vanc dose was ordered at 15 mg per kg, which is usually used to treat meningitis. So the patient also didn't have a lumbar puncture. So I'm thinking maybe for baby Sue that we want to kind of look at it more as far as bacteremia as opposed to it being meningitis. So I'm thinking maybe the dose was just too high anyways, and that we should kind of reduce it down to 10 mg per kg. I was looking at Neofax, and that's what it said there.
Okay, yeah, I hadn't seen that or even thought of that yet. That's a good idea. So let me see. I'll get a dose there. So it looks like if we do the 10 mg per kg, that'd come out to 6.8 milligrams, and then we'll stick with it every 12 hours. Does that sound good to you?
Sounds like a great plan. I know you had mentioned a little bit ago about a few changes to a few of the dosing.
Mm-hmm.
What other drugs were you concerned with?
Yeah, so that's pretty much it for the vancomycin. I was concerned also on the indomethacin schedule that we have coming up.
Okay, that's interesting. So you would recommend holding that dose, or?
Yeah, so I was actually looking through that, and she flagged up for a couple of contraindications for the second dose. It's contraindicated if they're suspected life-threatening sepsis, thrombocytopenia, or signs of significant renal impairment, which, our patient, I was going through her labs, her renal function right now, she's only at 0.8 mLs per kg per hour, and the serum creatinine is up at about 1.4, so somewhat elevated, especially for a 27-week-old. She's also thrombocytopenia. She has a platelets at 97,000. So kind of all those put together, I think it'd definitely be a good idea to hold that second indomethacin dose.
Yeah, those are all really good observations. I was kind of thinking about this earlier too. I see that the infant's having some aspiration, abdominal distension, perhaps her increased FiO2 needs are kind of just from this, not from the PDA itself. So another thing, I was also thinking kind of to support what you were saying, are her blood cells are shifted. The IT is greater than 0.2, it's at 0.33. So I really think that it could be more of like a septic kind of thing. That might be the reason for that increased oxygen need as well.
Okay, yeah, that's awesome. I definitely agree that kind of makes it seem even stronger. We should hold the dose. I'd be happy if you like. I'll go ahead and check with the attending after this and see if you'd like us to go ahead and remove that. Does that sound good to you guys?
Yeah, that sounds like an excellent plan, John. Now, how do you think that we should move forward to make sure this doesn't happen again in the future?
Yeah, that's something definitely a good idea to think about. I think number one thing is just proper communication. Appreciate you've been good to talk to. Not everyone's like that, here. Yeah. But I think it'd be a good idea to have some explicit reports. Especially like what exactly was implemented and the reason for doing so. Some kind of written documentation. That way, everyone involved, whether it's us over here at pharmacy or you guys, you'll have some patient's medication regimen, but understand some of the background things. And if we ever go against recommendations, just kind of have something written down as to why it is, and just some defense of their reasoning behind that. Yeah, I think that'd be good for everyone, just kind of get on the same page. And then also we've been talking about, I know they kind of pushed recently for kind of the SBAR communication, outside the situation and background assessment, recommendation kind of stuff. What do you think?
Yeah, I think that communication's definitely key, and using that standardized communication, I think we heard about that too, the situation, background, assessment, recommendation, allowing us to transmit all of the important information to one another while keeping everything pretty efficient. I wonder if the hospital computer system has anything to do with it too. Having maybe the capability to watch errors in the initial order, if the patient's correct diagnosis codes, such as it actually being bacteremia or symptoms such as that gastric discomfort, were properly coded or something in the computer, maybe an order for indomethacin could have just potentially been flagged and avoided altogether.
Yeah, I think that's an awesome idea. I know we have a lot of stuff like that down here in pharmacy. Go pop up a block for some drug disease, or drug-food interactions. I think it definitely sounds like something we could set up for like some lower limits on dosing based on like weight and age. Our IT pharmacist is actually in today. I'd definitely be okay checking with her on that. Besides that, what do you think about stuff regarding like correct drug protocols for the hospital based on some of those factors?
Yeah, I mean, I was kind of thinking about that. So, first of all, thanks for contacting the IT staff. I appreciate that. Now, regarding that hospital protocol, I think that maybe we can all get together, hold some meetings about maybe once a week or something, and then use all of our interdisciplinary knowledge to co-create these nomograms, maybe weight, age, dose intervals, or, for certain common situations that we have here in the NICU. I would be more than happy to, kind of meet with you at a further date. We can talk about that a little bit more. Now, what do you think we should do? Where should we go from here?
Yeah, I think that's a great idea, Taylor. I think definitely down here we'd love to add some kind of team-based meetings, with pharmacy, some nursing, maybe some of the physicians as well. So I definitely support that. Going forward from today, I'm just going to go ahead and file an occurrence report. Luckily we caught these, but even on the near misses, I just want to go and make sure those are filed. So that when we get to these meetings, we'll have some documentation, come up with some ways to prevent it from happening again.
Yeah, John, I think that's a great plan. Well, it's been good chatting with you. I look forward to working with you again in the future.
All right, I appreciate it. Have a good one.
You too.